Okay, hi. My name is Jay Yamahata. I'm a bachelor in chiropractic, registered in Japan, and we're doing this course, especially for the Bangladesh people that are coming to Japan to join our Palms Chiropractic College, MCSc. Okay, so I want you to know that there are two types of chiropractics in the world, and this chiropractic is based on the original Palmer techniques that we're doing. And the other techniques is called, the schools are called national type. Okay, so um, our school is a Palmer chiropractic, and the others are the mixers that we call national. So there are differences because chiropractic in the world is not a medical degree. It's nothing to do with the medical degrees. It's natural medicine, and we're focusing on the innate intelligence. Okay, the self-healing ability to treat the patient's body will have to treat all the symptoms or any diseases. We're not going to treat any of those. Okay? We're going to help the patient so that the innate intelligence will be able to be 100% within their bodies to heal any kind of diseases. Okay? And that is the philosophy of the Palmer, the original chiropractic. Okay. And the other mixer type is doing almost the same as the physiotherapists are doing. Of course, they're not medical doctors, but they're trying to treat the symptoms instead of doing the original chiropractic. And we are not those kind of chiropractic. And if any of you are interested in those mixers types, you came to the wrong place. Okay. So we're doing the original Palmer type chiropractic that is based on the principles, philosophy, science, and art of B.J. Palmer and D.D. Palmer. The founder is D.D. Palmer. Like I asked you all to read through the materials that I sent you, the introduction papers, and it is based on the founder is D.D. Palmer and his son is B.J. Palmer, and they wrote a lot of textbooks, more than 33 textbooks that you should be reading. All chiropractors should be reading. Okay, so in these we call it straight chiropractic. Okay? So Palmer type is straight chiropractic, and national type is called mixers. Okay, so we are providing straight chiropractic to you, and the course contains the straight chiropractic. It's Thompson techniques and Gonstead techniques, AMCT, that is activator method, mainly, and of course toggle recall that BJ Palmer used to do. Okay, so we're finding the subluxation. The subluxation is the area that is interfering the nerve flow from responding from the universal intelligence that is the what God, and we receive it from the brain. Okay, and we receive it from the brain, and we call that the center. The center is the brain. Okay, so we receive all these informations that is provided that could heal any part of the body. Okay, we have 100% of healing ability when we were born, but since there's a interference of the nerves coming in and out of the IVF, the inner vertebral foramen, if it is subluxated, that will interfere the force from the center to the peripherals. And the peripherals are the areas that the patient has diseases or any kind of symptoms. And we're not going to treat those symptoms itself. We're going to treat the cause of the symptoms or the diseases. That is the subluxated segment in the vertebral column. Okay. It's not what you think is what most of the Asian chiropractors, like Indian chiropractors or chiropractors in Bangladesh, they think they're cracking the spine to take away the treat the pain. Okay, we're not doing that. Okay, so the pain is an effect. The disease is an effect. So we're gonna find the cause of those symptoms, and we're gonna treat that one single segment that is interfering the nerves. Okay. So it's a one segment adjustment. It's not well, we're not going to rotate the spine to make crack sounds. Rotating the spine will not open the interference of the pulsation. Okay. The only way to treat that is to take the pressure off the nerve at the IVF. Okay, and there are two types of subluxation. One is the facet joint subluxation, and one is the disc degeneration. For disc degeneration, we're going to use Gonstead techniques, and for the others, we use Thompson's, or for the facet joint, we use Thompson activator methods, okay, or toggle recoil. So BJ Palmer technique is the original techniques that we're going to discuss. That is a toggle recoil technique, but before doing that, we should do the Thompson technique, okay? So please read through the materials, okay? Because we don't have much time, okay? And we will provide you all the previous videos for each techniques. And after this session, I'll tell you where to start. And if you have any questions while watching those videos, you can ask me on WhatsApp. And if there are similar questions, I could do a special video online for those questions. Okay. So for the classes, we'll provide the all the materials we have. Okay. Okay. So let's go to the slides. Okay. So these are the slides that I've already provided. So let's just go to the introduction very fast. Okay. So this is D.D. Palmer, the founder, and B.J. Palmer is the developer. Most of the techniques are developed by B.J. Palmer. Okay. So these techniques, Gonstead method, diversified technique is actually a Palmer technique that we're doing, including the toggle recoil, and Thompson technique. Thompson technique was developed by Clyde Thompson. He was a student of B.J. Palmer, and he developed the drop table, okay, and for B.J. Palmer. Okay. At first, he made a cervical, upper cervical drop piece for the C1 Atlas adjustment. And that was the major subluxation that B.J. Palmer found. So if there's any impingement at the atlas, anything below or above the atlas may be interfered. Diseases in the head or in any part in the body. Okay. So adjusting C1 can treat any kind of symptoms or any kind of diseases. That's what B.J. Palmer thought. So that he made this hole-in-one concept. It's like golf, hole-in-one. So you adjust atlas and it treats everything. Okay. It's called hole-in-one, or we can call it upper cervical chiropractic. Okay. That is a B.J. Palmer technique that you use recoil. Okay. That is the starting of the toggle recoil techniques. Okay. And we could use activators and SLT. We're not going to use this. We're going to do this in a DCS course. Okay. So this is the subluxated area. So this IVF here, the nerves coming in and out, and corresponds to the Merrick's system. That is the it's like the patient has a liver problem that is associated to T4, 5, because the nerve supplies comes from this T4 and 5 to the liver. So we do the nerve tracing using the Merrick system and find the subluxation by using a palpation or an X-ray, and treat this one spine that is irritating this nerve between the one above and the one below. So we have to adjust this one spine very specifically without moving the one above or the one below. So this one single spine is irritating these nerves. If we twist, all these components above and below will move together. So this this subluxation will not disappear, and that will not fix any kind of diseases. It may take away the symptoms like the pain of this region, but it will not be chiropractic. That will be more like a massage. Okay. So we're not training you to become a massage therapist. We're training you to become a chiropractor. And to become a chiropractor, you have to know the principles of chiropractic and, of course, the principles of subluxation complex. Okay. So chiropractor is treating the subluxation only. Okay. We're not treating the posture. We're not treating the symptoms. We're finding the subluxation and we fix it, bring it into space so that these nerve entrapment will be free. Okay. If these nerves are free, these nerves from the center, that the information that was received from the universal intelligence will go from the center and through the spine and go out from the IVF and go to the peripherals, and that will treat any kind of diseases. Okay. So we have to, it's like a 2 to 3 millimeters adjustment. Okay. So this is, we have to bring this back into space about 2 or 3 millimeters. We go beyond that, that's going to be too much force, and that is going to make the nerve impingement worse. Okay, so it's going to be very difficult to adjust it very specifically, and that's what we're going to train you to become. Okay, if you try to force it, all the components will move and make a very loud crack sound. Okay, and that is not chiropractic. That is just going to make a loud crack sound, and the patient will feel better. Okay? Like a massage. Oh, well, that feels good. Wow, that crack sound is cool. Yeah, but it's not going to treat anything of these nerve supplies. Okay, so that's not what we're going to do. We're going to just do a single segment adjustment very specifically. So we have to find this. Okay, and there are a lot of ways to find this. Okay. We're going to teach you the Thompson reflex leg length test. We call it Deerfield test. And also we're going to teach you how to do the AMCT activator method using the leg length as well, but it's going to be a different way to differentiate if it's a subluxation or not. Okay. And also we're going to do a X-ray analysis using the Gonstead method. Okay, especially for the disc degeneration, because if there's a subluxation, there may be a facet joint problem or disc degeneration that is slipping the spine posturally and jamming these nerves. Okay, or maybe both. Okay, so Gonstead thinks that these facet joint problem is secondary to the disc degeneration. Okay, And Thompson or D.D. Palmer, B.J. Palmer thought it can be fixated, subluxated, just the facet joints, okay, without the disc degeneration. Okay. So we are training you to differentiate if it's a disc degeneration, subluxation, or a facet joint subluxation. And according to these subluxation, the findings, we're going to do a specific adjustment for each disc or facet joints. Okay. It's nothing that you see on YouTube. Okay. It's not like those. Okay. They say they're doing chiropractic, but actually 99% of the YouTubers that the videos you see on YouTube or Facebook or social media, 99% is not chiropractic. It's a cracking technique. Okay? And they're not chiropractic. They're not chiropractors. The people that are teaching the DCs or chiropractors of USA that is teaching those cracking techniques on YouTube or coming to India or Bangladesh to teach those cracking techniques are not teaching the original chiropractic. They're teaching to make money, okay? Because loud crack sounds are what people wants to do, okay? They're corrupting chiropractic actually, okay? Because they can make more money teaching those techniques instead of these original techniques that is much more effective, okay? So for the facet joint problem, the direction of force will be towards this closing the facet joints, and the direction will be according to these facet joint line. Okay, the vector will be towards this facet joint plane, and of course, if there's a subluxation, it will be one side, right or left. So there will be a swelling at the facet joint capsule on one side. So let's say there's a facet joint swelling, and that swelling is impinging the nerves coming in and out on the right side. The right side will rotate posteriorly. That doesn't mean that left side will rotate anteriorly, because the facet joint will fix the left side from moving anteriorly, because there's a bony aspect in front of the facet joints. It will stop. Okay, so the only direction that the facet joint subluxation may occur is posteriorly. Okay, there's no such thing as anterior subluxations. Okay, so and the rotation is not interfering the nerves at all. Okay, there may be a sprain, and that is not a subluxation. That is a hyper mobility. Okay, so treating the sprain is not our goal. Treating sprain is for medical doctors. Okay, they put ice on it, or do massage on it, or give them medicine. Okay, or surgery. We're not a surgeon, or we're not a medical doctor, so we're going to do our job is to push the inflammation, the swelling into space. So the direction, it will be P to A, posterior to anterior on one side without rotating. If we rotate it from right to left, the right may be moving anteriorly, but the left will move posteriorly, and they will make a left subluxation after the fixing the right. Okay. That's why a lot of those YouTubers try to do the adjustment on the right and the left at the same segment. Okay. And they will have to do that forever. You fix the right and they make the left, and they fix the left and make the right. So, well, the subluxation will remain forever on both sides. Okay. By actually making a box crack sound, it will like make it numb, so the pain will relieve. It's just making it numb. Okay, it's not fixing the nerves. It's making it numb, because if you like punch your face a few times, it will get numb. It's the same thing. Cracking your knuckles a few times, it will get numb. But cracking your knuckles, is it staying like that? It's going to be, you can crack your knuckles in every 5 minutes. It's not treating anything. Okay. And these are the vectors for the facet joints. So for the disc, it's going to be in this plane of PTA on this disc line. Okay. Disc plane vector. It's going to be P to A. Okay. We're going to bring the posterior slip one segment back into space, P to A. Okay. Because if there's a slip posteriorly of this single segment, there will be an inflammation at the disc level. Okay? And that inflammation of the disc will be impinging the nerves coming in and out. Okay? The swelling. So there will be swelling at the disc or the facet joint, and we're going to push in that swelling. Okay? And that is about 1 to 3 millimeter force. Okay? So you can actually adjust any kind of subluxation using an activator. Okay. Okay. So this is the introduction level that I should not have talked right now because I might be wasting your time. Okay. Because you could study this on the materials. Okay. Let me back to give you. So we're going to the Thompson. So let's just go through the Thompson theory. Okay. Just a minute. Where'd it go? Okay. So Thompson theory is based on B.J. Palmer's theory as well. Okay. So where to start is based on the major subluxation um, theory. So if we should treat the major subluxation first, okay, because the secondary and the third tertiary subluxation will be compensation of the major subluxation. And most of the patient will have a chronic or an acute cervical subluxation. And if there's a cervical subluxation, like I told you, the nerve supply will come from the center, from up to down to the coccyx. Okay? So if there's a subluxation that's cervical, everything below the cervical will be corrupted. So if the patient has a major subluxation in the cervical, we should treat the cervical before going to the pelvic. Okay. If there's no subluxation or major subluxation at the cervical, we start from the pelvic region. Okay. So the major subluxation will be the cervical syndrome or the pelvic syndrome. Okay. So in this first visit of the patient, we will only adjust the major subluxation without going to the secondary subluxation. That will be the lumbar or the upper thoracic. Okay. So the major subluxation will be the cervical or the pelvic, or maybe both. Okay. And the secondary will be the upper thoracic and the lumbar. Okay. We're not going to the lower thoracic unless all the major subluxation and the subluxation are 100% treated. Okay. So if you see a chiropractor that is adjusting the cervical and the pelvic and the thoracic at one visit, he is not a chiropractor. He is not educated. You can tell. Okay. So every chiropractor has the education in this concept. So we follow, we 100% respect all the pioneers that has discovered in this 120, 130 years of experience in the chiropractic field. Okay. So if you try to adjust the thoracic without checking the pelvic or treating cervical syndromes, you're just it's a disrespect to all the chiropractic society. Okay, okay. So everybody should know this. If you don't know it, you're not a chiropractor. Okay. So the major subluxation will be the cervical syndrome or the pelvic. Okay. Unless the major subluxation disappears, we're not going to the lumbar. Okay. But this pelvic includes L5. Okay. So L5 is an exception. Okay. So L5 is a part of the pelvic. Okay. As it will be major subluxation. So the secondary will be the upper thoracic and the lumbar region, that is L1 to L4. Okay. And the others will be the third, tertiary. Okay. So like 99.9% of the patient that comes into your office with some kind of disease or symptoms will have a cervical syndrome or a pelvic issue, or maybe both. Okay. Even if the patient has a stomach pain or a headache or any knee complaints, shoulder complaints, we're not going to the shoulders or these regions. We're going to find the center, okay, the major subluxation. Okay. So do not follow the symptoms. Okay. Don't follow the diseases. Okay. We could track the major subluxation by finding the diseases, but we're not going to treat the disease itself. Okay. We'll talk about the nerve tracing when when you come to Japan, when we do the practical. Okay. Okay. So the major subluxation, we're going to find a major subluxation, and by checking the leg length in a prone position. So in prone position, with the knees extended, we're going to find the short leg side, original short leg side. That will be the contracted leg. Okay. Neurological contracted leg. Okay. Short leg. So in this picture, the left picture is right short leg. So this is the original contracted short leg on the right. Okay. And we're going to have the patient to rotate their head to the right and the left. Okay. And if the patient rotates their head to the short leg side and the short leg gets longer, even or longer than the left leg, that will be a right cervical syndrome. Okay. Right cervical syndrome means that when the patient looks to the right, there's a left posterior subluxation. Okay. So when the patient looks to the right, that will correct the left rotation. Okay. So that the nerve interference will disappear for about 3 to 5 seconds. Okay. So you have to do this very quickly. Okay. Actually, 3 seconds. It's a 3-second rule. So you're going to have to see the patient leg without in a prone position, a neutral position, and ask the patient to look to the right. And within 3 seconds, you're going to see if the right leg is longer or even. Okay. If it doesn't get even, we're going to have to ask the patient to look to the opposite side, the contralateral side. That will be the long leg side. That will be left. And if the right leg gets longer when the patient looks to the left, we call that the left cervical syndrome. That means there's a subluxation on the right side. Because if there's a posterior rotation on the right side and the patient looks to the left, that will correct the subluxation. Okay, the right rotation to the left rotation. Okay. And that will respond the bulbopecular formation, that is interrupting the 1A neurons to the center, and that will respond to the postural muscles. If there's a subluxation, the bulbar reticular formation will be activated by the bradykinin, that is swelling of the subluxated facet joints or the disc, that will interrupt the the bulbar reticular formation that is going to the brain, okay, through the IVF, okay. And if there's a subluxation, the formation of these response will be different from the cerebellum and the cerebellum, the cortex. Okay. And that will make one side of the muscle contract and the other side will be inhibited. Okay. So we call it the facilitatory inhibition response. Okay. And one side contracted leg will be the contracted side, and the opposite side will be the inhibited side. Okay, if there's a subluxation, and one leg will appear shorter. Okay, if we treat the subluxation, these leg will get longer. Okay. Okay. So, and we're going to fix that using a drop table, or with or without a drop table. We could do Gonstead techniques or activator techniques or Thompson technique, recall technique, anything to treat this subluxation. Okay. Okay. Now, if there's a subluxation at the facet joint in the cervical, there will be a nodule. Okay. There will be a pebble-like swelling nodule at the facet joint. So that will be the contact point. That will be the posterior rotated facet joint. Okay, the swelling will make a nodule. Okay, we call this nodule here. You spell it like this, nodule. My English is American English, so maybe the British people, Indian people, or Bangladesh people are using British English, so maybe you can call it nodule. Okay. So this is how you spell it, nodule. Okay. In English, because chiropractic is American, I use American English only. Okay. So nodule. And if there's no nodule, it will be a C1 lateral shear on the side that will be the opposite side of the cervical syndrome. Okay. Okay. So we adjust that. If there's no cervical syndrome, that means that the patient looks to the right and left, and the short leg remains short. Okay. It doesn't go beyond even. Okay. So that means the patient does not have a major subluxation in the cervical. There may be a subluxation, but we can treat that later on after treating all the pelvic subluxation. Okay. But if there's a subluxation, a cervical subluxation that is major, we have to treat the cervical subluxation before we go to the pelvic. Okay. 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 So now let's just do the leg vent test. Okay. So my partner Tomoko, my wife, let me introduce you. My partner. Okay. She's been Tomoko. She's actually the chairman of the association. Okay. Tomoko, she's my wife, and she'll be.
Yeah, welcome, ma'am. Good afternoon. How are you?
I'm fine, fine. Thank you.
Hello, ma'am.
Hello.
Okay.
Hello,
So-
morning, ma'am.
Okay. So this is a drop table. Okay. So if you don't have a drop table, you can use a normal chiropractic table. Okay. We're gonna have the patient to lie down in prone position from the end of the table, so she won't twist. Okay. And the face should be in neutral position, and the EOP of the occiput, okay, and the midline of the spine, and her gluteus fold, and both feet should be in the center line. Okay. And the headpiece should be neutral as well when we're doing the evaluation. Okay. So this can be declined like this, okay? But when we're doing the evaluation, this should be leveled. Okay. Okay. And the foot piece we could extend this like this. Okay. So the dorsal aspect of the patient's feet will slightly touch. Okay. It will slightly touch the end of the table, the foot piece. Okay. So this is a foot piece of this. Okay. So it won't touch it. It will slightly be off. Okay. Okay. So these the EOP and the gluteal fold center of this should be in the center of both feet. Okay. So we're not going to grab the ankles. We're going to cup the ankles and bring it into center like this. Okay. And then take the pressure off. Okay. If one side, not both sides, if one side bounce back very strongly like this, if it goes like this, okay, she does actually, that may be a sign of cervical C2 posterior rotation. Okay, so if the left side, in Tomoko's case, I try to bring it into center and the left side bounces back into abduction. Okay, right side doesn't, so it's a unilateral subluxation as C2. Okay, so she has a C2 subluxation on the left side. She may. Okay, so we have to check. So and her knees should be slightly flexed. So we could lift this piece like this. So the knee extension lock will be loose. Okay, don't flex it too much. Just enough to unlock the knee extension lock. Okay. Okay. Or if you don't have these pieces, you could just lift it up. Lift it up. So there's no friction of the tibia on the table. Okay. Take the friction off the table, and your thumb is anterior to the calcaneus, okay, about the level of the cuboid. Okay. And we're going to take away the inversion to make it flat. Okay. The heel flat. If there's any rotation, don't disturb the rotation. See it as it is. Don't bring the rotation off. Okay. So the only thing we're going to do is bring the inversion into straight even. Okay. Make it even. Okay. And see the seam of the heel. Okay. And see which leg is short. Okay. So use these activator method shoes, leg length shoes. If you don't have, you could use the patient's shoes, okay? Sneakers, okay, or maybe normal shoes that the patient is usually wearing. like the right side is in inversion. So I want to make it straight, both. And we're gonna see the line of the heel, not the shoes, okay? Because if this is worn out, it's not gonna be straight. So this area will be straight, right? Where the patient's heel touches the shoe, okay? So we're gonna see this white line, not this black line, okay? And we're gonna take the friction off the table like this, lift it up about 1 centimeter, and bring the inversion out, and we're going to see in this vector. Okay, and you can see that the right leg is shorter. Okay, right leg is short. When you do that, I'm just doing this just to show you, but actually do not place both feet together. Okay, slightly off, about 2 inches away. Okay, don't put heels together. Okay, about 2 inches away, and see in this line with your dominant eye. My dominant eye is the right eye, so my body is slightly towards the left. Okay, so my right eye will be in the center of the gluteal fold line. Okay, so this space between these two legs will be in the center of her prom line, their gluteus fold, and I can see that the right leg is very short. So this is extended position. Okay. Now I'm going to find if she has a cervical syndrome. So I'm going to ask the patient to look to the right, the short leg side, call me, okay. And within 3 seconds, if the right leg gets longer, it's not responding. So she does not have a right cervical syndrome. Okay. So back to neutral. Recheck, always recheck. So it's short, right, still short. Look to the left. Okay, and the right leg gets even, okay, or longer. Okay, right was short, but it gets even when she looked to the left. Okay, she's looking to the left. That means she has a left cervical syndrome. That means there's a facet joint swelling on the right side. Okay, when she looks to the left, we call it the left cervical syndrome, but the subluxation is on the right side. Okay, so we have to find the tender point, that is a swelling at lamina. Okay, so ask the patient to tuck their chin down and find. Most of the cases it will be C2. Okay, but there's no swelling on the right side on C2. So I'm going from C2, 3, 4, 5. So I find something at 4, level 4. I'm using my middle finger tip. Okay, and and this is tender. Okay, this is tender spot. Okay, we call this a nodule. If there's no nodule, it will be a C1 syndrome. Okay, but she has a nodule at not at C2, but she has a one at C4. Okay, so I could use activate to adjust it or anyway. But in Thompson, I use a knife edge here. I use my knife edge. Okay. When you adjust it, we're gonna slightly flex the headpiece. We're going to flex this about 15 to 20 degrees so that the weight of the head will be doing a little traction. Okay. Okay. And we're going to ask the patient to look to the left. Okay. So that if there's a right subluxation and she looks to the left, the other cervical will rotate anterior on the right side, but the subluxation will remain, so it will be easier to find. Okay. So you should stand on the positive side and and find that pebble and with one finger, and you're going to use this knife edge here to, and this line of drive of my arm will be towards the plane line. So it's C4 is actually the medial cervical will be at 90 degrees medially. Okay, I'm going to do a little traction with this my left hand using a chiropractic arch on the zygomatic arch and do a traction, and the force using drop. I could just elbow really down because she's already rotating, so the direction will be medially with my right hand. Once. Adjustment is once for the cervical. Now I've already done the adjustment, so I always recheck, post check. Now after the adjustment, I can see that the right leg gets longer. If I made a mistake and adjusted too strong or moved another segment, the right leg, the original short leg, will get shorter, okay, or remain short, okay? But it's getting longer. Okay. After the correction, we have to reset the nervous system by flexing the knee over 60 degrees twice, okay, like this, twice. And if there's any other subluxation, the right leg gets short again. Okay. Okay. So she has another subluxation, so she has a right short leg after resetting. Okay. Okay. So I could ask her to look to the right again. Remain short. Look to the left. Remain short. So the cervical syndrome is gone. Okay. So we could go to the pelvic region. Okay. So this is the difficult part. So there's two types of pelvic issues. One is the PI ilium, and one is the AI sacral base on the short leg side. Okay. So in Thompson or Palmer technique, there's only the major subluxation for the pelvic is a PI ilium or a sacral AI sacral base. Okay. So AI sacral base on the short leg side is 85% of the patient is AI sacral base. Okay. We call that Deerfield negative. Okay. And for the PI ilium, it's an SI joint problem that will be the remaining 50% of the Deerfield negative. So that is very rare. Okay. So to differentiate if it's a we call that Deerfield positive for the PI ilium. Okay. So it is to differentiate if it's a Deerfield positive or negative is finding the right short leg in extension and bring the knee joint into 90 degrees flexion and see the height of the heel. Okay. If the right, and this center of this feet in flexion 90 degrees should be in the middle center of the gluteus fold line. Okay. And these heels should not be touching. And I can see that the right short leg gets longer, higher in flexion in 90 degrees. That is a sign of Deerfield positive. Okay. So we call that short to long. Okay. Short to long. Okay. Short to long is a Deerfield positive. That is a sign of PI ilium. Okay. Deerfield positive. Okay. If it is short and position flexion position is still short, it is Deerfield negative. That is a sign of AI sacral base on the short leg side. Okay? So the sacral base is tilting anteriorly inferior on the right side. Now that left side is neutral. So the sacrum is rotating to left in this left oblique axis. Okay. Okay. So if she has a Deerfield negative that is common, we will be adjusting the sacrum. Okay. And if it's a Deerfield positive, it will be a SI joint problem, PI ilium. Others like AS ilium, IN, EX ilium is a secondary. It's not even a secondary subluxation. It's a compensation. So after treating the major subluxation, secondary subluxation, and the thoracic, after all those are treated, we could go to check for the AS or IN or EX. Okay. So we're not treating it until we do the whole spine. Okay. So if she has a Deerfield positive, we will have to be checking if the PI ilium is PSIS rotating posteriorly against the sacrum or the pubic bone rotating anterior superior. So we call that an upper boot subluxation or lower boot subluxation. We'll be talking that in the Deerfield positive video. Okay, I'll be sending you both negative and positive. Okay. So for these techniques, I'll be showing you in the videos. Okay, but just let me just do a sample without the instructions. Okay, so how we should perform these adjustments. Okay. So if she has a Deerfield negative on the right side, the sacrum base will be rotating anterior inferior on the right side, and the pelvic will be rotating posteriorly. So in a X-ray, the Deerfield not positive and negative will look the same, because if it's a sacral base that's rotating anteriorly inferiorly against the ilium, it will look like a PI ilium, anyways. Okay. But it won't be treated. The subluxation won't be treated unless you contact on the sacrum if it's a AI sacral base. Okay. So if she has a sacral base, AI sacral base on the right side, I will use the ischium to bring the inferior sacral base on the right side superiorly up, okay, stabilizing the PSIS. So I'm gonna hook my heel of my palm under the ischium process so I can lift it up and flip it posterior superiorly so that the pelvic itself will, the ilium will rotate anterior against the sacral base. Okay? And the sacrum will lift up, because if it's an AI sacral base on the right side, the sacrum is side bending to the right. Okay? And there will be an open wedge between the L5 and sacral base on the right side. I do lift this up. Because she doesn't have one, I'm going to use it first. Just a sound. Stabilize it. Adjust the sacral base up. We do that 3 to 4 times. If it's a drop table. If it's an adjustment, it's once. Okay. After that, if there's a AI sacral base, the sacrum, it will be tilting anterior inferior, and PSIS will be moving inwards. We call the IN ilium. Okay. So after the side bend of the sacrum, we should be adjusting the IN ilium by using the ischium process. Okay. So we're going to stand on the contralateral side and find the ischium, and medial to the ischium, I'm going to use my superior pisiform of my chiropractic arch and adjust it 3 to 4 times. And that is the prone adjustment. There's a supine adjustment that I could show you. She has a right. So there's our two-part adjustment. Okay? One is the lifting the inferior sacrum, okay, using the issue. Okay? So I could have her to flex her right hip joint into 60 degrees and her knee into 90 degrees. Okay? Table up and use your knuckles here to contact on the ischium process, okay? And stabilize the ASIS medially. Okay? And the adjustment will be pushing the ischium, just like I did in the prone position. I'm going to push the ischium process up to lift the sacrum up. And 3 to 4 times. After that, if it's a IN ilium, the ASIS will be lateral. So I'm going to use her inguinal ligament on the positive side to bring the inguinal ligament medially. So the inguinal ligament will pull the ASIS in and the PSIS out. That is an adjustment for the IN ilium for the second component of this adjustment. In that way, I'm going to flex the contralateral leg so I can stabilize this with one hand and use my knife edge or my thinner eminence lateral to the inguinal ligament. I could force it, I could torque it medially. If it's the right side, I'm going to torque my hand clockwise. So the ASIS will move medially, and that will force PSIS to move laterally. Okay. And weak. Because it is very painful. It's very weak. Okay. It's torqued like this. Because she doesn't have one. If she had it, I would do it much more stronger. And that is the supine technique. But I usually do the pre-check and post-check in the prone position on the leg length. So I don't want her to look face up and down again. So this technique is rare. I usually do it in prone position. Most of the chiropractor does it in prone position. So this is just one sample. If the patient cannot tolerate prone position when we are doing the adjustment, we'll do it in supine position. Okay. And always when you check for the leg length, we're going to have the patient do in a prone position. Oh. So her right leg is very long now. I don't know why, because she doesn't even have a Deerfield negative. Maybe it's a secondary negative. Okay. But it's corresponding and it's getting longer. So I could reset it twice, flex twice, and it remains long level. So I don't have to do any adjustment. For the positive part, there's two types. So you have to do an arm fossa test, like a muscle testing, to find out if it's an upper glute subluxation or lower glute subluxation. But if it's a lower glute subluxation, it will be a PI ilium like this. So the PSIS will be rotating posterior, inferior. Okay. So in that case, I could stand on the positive right side, contact on the BSIS with my thenar eminence, so I could rotate it anterior, like doing torque on the BSIS. As I stabilize the opposite contralateral ischium process. Okay? So the adjustment will be with both hands, but the direct hand will be the right hand on the BSIS. Press it. Three or four times. A gentle thrust. And it's actually longer. Reset and check. It remains long, and even in position flexion, and it's even in extension. So there's nothing else I should do to her. I should not go beyond this for today. So I could do some cranial work for visceral manipulation or something else, but not any other adjustment. Because it's going to ruin the whole nervous system if I do much force in her body. It will be too much information for her brain to absorb. That will make another disease. Okay, so that's how. So for more details about this Deerfield negative and positive cervical syndrome and everything, it's all in the online videos that I will be sending to you. Okay, and I want to ask all of you to go through these materials and these videos, and if you have any questions, you can ask me anytime. Okay, and to make it more effective so that you will, for further understanding, I should not do on time live video like this. Okay, if you have any questions that you want me to show you, I will be happy to do that. Okay, so we'll plan for some videos. Okay,
Anybody having any question, please ask, sir.
Yeah.
Professor, please.
Okay, sir, thank you. I understand what sir taught.
Yeah.
That was very easy to understand. Sir gave a lot of efforts, as we all can understand. So the materials you have provided, I hope, and I will do the make sure that all participants should go through, and they will watch the video and will try to understand everything before coming to the Japan.
Yeah. Okay, if you have any questions, if any participants has any question, we could do a follow-up session online, okay? Instead of a class, okay?
Yes, sir.
Okay. So that will be all for today. Just turn the video off, okay?